Hello, I am Leanne Magee. I'm a pediatric psychologist with the Children's Hospital of Philadelphia, Cleft Lip and Palate, and Craniofacial teams. And today I'm going to be providing a brief overview of the psychological impacts of cleft lip and palate and associated care throughout childhood. We will focus on strategies that parents, caregivers, and providers can use to help kids and teens cope with medical care, appearance concerns, and social challenges in ways that help build resilience and increase quality of life. We're going to focus on what psychosocial issues can emerge for families who are treated in our team settings, who might be at greatest risk for challenges due to broader effects on their psychosocial functioning, identify why psychosocial services can be a key component of team care even when dedicated psychosocial staff are not available, and then we'll review some strategies for when, where, and how we can support our families as they navigate psychosocial challenges throughout ongoing cleft and craniofacial care. Children and families affected by cleft lip and palate will face various challenges throughout all stages of care and development. Early on, our families are tasked with learning about and accepting a diagnosis and coping with early surgical and medical care, in addition to interventions that help facilitate feeding, growth, and development. As children age, they become aware of these challenges and complexities of their medical visits and surgeries, while also navigating risks for learning difficulties, complex social dynamics in their school and community environments. For many, this can include coping with social difficulties, teasing, or body image and appearance concerns on top of their medical care burden. Through extensive research, we have learned that overall, children with cleft and craniofacial conditions do face unique psychosocial challenges. They are at risk for developmental delays, requiring early intervention services, early feeding and growth difficulties, speech and language delays, fine and gross motor delays, as well as risks for vision, hearing, and airway. Hearing loss can further impact language acquisition, and along with speech difficulties, contribute to challenges with communication. As our patients age into the school years, they exhibit an increased risk for learning difficulties and associated challenges navigating the school special education services for learning, speech therapy, and occupational therapy. Social challenges like teasing and bullying, coping with appearance differences, and managing the stressors of medical, surgical, and orthodontic care. These stressors can persist into adolescence and young adulthood and can contribute to difficulties with school, social, family, and professional functioning. Though most kids with cleft and craniofacial conditions are very resilient, cleft and craniofacial related stressors put children at risk for psychosocial difficulties. Research demonstrates that compared to unaffected peers, cleft and craniofacial patients show lower self-esteem, higher rates of internalizing disorders such as depression and anxiety, higher rates of externalizing disorders such as behavioral issues, greater reported frequency of teasing, and less satisfaction with their facial appearance. Research across adults with visible differences suggests that while many adjust well, some struggle with appearance and experience significant psychological and social impacts, which can include low self-esteem, body image concerns, and difficulties with social interactions. Among teenagers with cleft and craniofacial conditions, psychological adjustment is predicted by perceived problems with speech, coping styles, and social experiences, including the frequency and quality of social interactions, family support, social stressors, and the presence or absence of teasing or bullying, as well as with satisfaction with appearance, which does increase with age. Appearance concerns can often be closely related to the experience of anxiety and depression, and include fears of being negatively evaluated by others, negative thinking patterns, including critical self-talk, behavior challenges such as avoiding social situations, and other emotional reactions, including anger, guilt, and grief. However, the extent to which someone with appearance differences experience difficulties in this domain is mediated by resilience factors, such as their coping styles, thinking styles, behavioral responses, and social supports. Because of these complex risk factors, psychosocial assessment and intervention needs to happen over the course of time. Regular screenings for psychosocial needs are critical, as a patient's or family's needs and concerns can change with their developmental stage and the stage of treatment. Importantly, the interventions must be matched to the patient's developmental stage and target both their interpersonal and intrapersonal impacts of their condition and treatment. In our cleft and craniofacial teams, the psychosocial assessment is something that occurs every year or so and takes place in a 15 to 30 minute visit in the multidisciplinary team setting. In that 15 to 30 minutes, we're trying to assess how well the patient and family understand their condition and its treatment, what their developmental functioning is and what services they may be receiving, how are they functioning in school and family and social settings, how is the patient and family coping with mental health in terms of depression, anxiety, and other mental health concerns. Did the family or the patient have any specific appearance concerns? How are they coping with their care or maybe care that might be coming up? And then working to identify some barriers, challenges, and resources that might be critical to helping them succeed in their clinical care. As a clinical provider, we can also encourage our patients to have a lot of resilience throughout ongoing medical, dental, and surgical care. This involves a number of strategies that can take place before, during, and after that care is delivered. First, we want to know each child's specific risk and protective factors. Understanding a child's resilience factors and strengths will help us know best to support them. If they have an area of risk personally, situationally, or even within the family, that might be an area that we can step in to help a little bit more. So if a family has unstable housing, or if a child has really specific fears and worries, knowing that can help us deliver tailored care. We also want to share appropriate information with kids and keep them involved. We want to discuss with our patients at a level that's appropriate to their age, what their condition is, and what their treatment will involve. We want to give them honest information, because if we don't do this, often they imagine the worst. We want to use language that is simple and descriptive and let them know what we are doing and what it's going to help with. But we don't want little kids to hear more than we intend. Just because we're not talking to them doesn't mean they are not listening. If there are more complex or riskier discussions to have that might not be appropriate for young kids, it can be important to have some time to talk with parents and caregivers one-on-one. However, we do not want to keep secrets. Nothing challenges trust in parents and the medical providers like telling a lie or not the whole truth about what's happening. We want to trust in kids' ability to cope when we can provide appropriate supports. The next thing we can do to build resilience is plan for procedures. We want to try to make sure the child understands what they will be facing, what's going to happen, where, when, how long will it take, what might it feel like. Some kids do better with a few days or weeks to prepare for a medical procedure, while others might worry excessively if we tell them too soon. We want to communicate at the level that works best for that patient, so they know at a minimum what to expect and when. If a procedure is going to cause physical or emotional distress, we want to be prepared and help that child get the support they need. This can include support from the care team, including a psychologist or social worker. It might be a caring family or friend, or even just distraction strategies in the office. One other thing we can do is, when possible, give kids choices. Some medical procedures must be done no matter what, while others can be more flexible. Find out from your team what options you have, and if there is an opportunity for choice, it can help kids to feel more in control of the situation if they're the ones who get to choose. An example might include doing parts of a medical exam in a certain order, holding or not holding your hand, pressing a button for various things. We also want to focus on the rest of the family. Parents, partners, and siblings can sometimes get lost in the shuffle of caring for a child with a chronic illness or a cleft and craniofacial condition. Those family members face struggles of their own and may also need support. Lastly, we want to keep our kids and families connected. Managing a health condition like cleft palate or craniofacial conditions can mean lots of missed school and activities, which can lead to feelings of disconnection from friends. We want to try to keep our kids connected to the people and activities that they like to do. We want to coordinate with schools to minimize the impact of absences and to help school providers understand why kids are out from school. We want to make sure that kids are getting plenty of playtime with their friends, and we also want to consider connecting our patients and families with others who are managing the same conditions. Having a single positive connection with a peer, engagement in a fun activity, or connection with an adult trusted caregiver can be very protective and help buffer kids against the challenges of less supportive social situations. Connecting with other families is a way to decrease a sense of isolation that many kids and families can feel and builds a sense of community that can support and strengthen them. Furthermore, when kids face social challenges such as questions, teasing, or bullying, we want to help them distinguish between what's a curious question or behaviors that might be more targeted and hurtful, such as teasing or bullying. We can help our patients and families understand the situation by asking about what was said, how it felt, and how they were treated, to help model some ways of taking perspective and making choices about how best to respond. Having a strategy to manage stressful social situations can help elicit more positive reactions and interactions with others, and in turn help our patients have a more positive view of themselves. One of the strategies to help target nonverbal communication uses the acronym STEPS. You can work with patients to practice these skills so that they can build their confidence and their social skill. S is for self-talk, including positive and affirming statements about oneself. T is for tone of voice. We want to practice with kids how they can speak clearly and at an appropriate volume so they can be heard. E is for eye contact, looking people in the eye and talking and also listening. P is for posture. We want to help our kids practice an upright posture, shoulders back, head up, hands away from their face, so that people can see their confidence. And lastly, S is for smile, which helps our kids communicate friendliness and confidence. Now, many children, especially young kids, can get nervous or anxious when they are asked a question about their difference. This is natural. Many will respond by not saying anything at all, or maybe saying nothing. Oftentimes, these non-responses can result in the other person becoming more curious, kids making up reasons for the difference, or our kids being targeted with repeated questions that can start to feel like bullying. So what we found is that it can be very helpful for individuals with a visible difference to practice a one-liner response to anticipated questions or common comments that they receive about their appearance. Responses tend to work well when they include an acknowledgement of the difference and a brief and age-appropriate explanation, followed by moving the conversation on. First, we want to encourage kids and families to acknowledge and label the difference. We want to try to use neutral, descriptive language. You can say as much or as little as you wish, and how much you share may vary depending on your mood or the situation. Often, when we share about our difference, people might express worry, confusion, or concern. Providing some reassurance can both educate them about the visible difference and also help them understand how you might feel, which can help them know how to respond to you. Last, when we are ready to move on, it can be helpful to redirect, change the topic, or ask questions. For kids who are old enough to do so, I recommend some role play with their team providers, their parents, or a family. Writing down a response can also be helpful, and practicing with kids before they enter a new social environment, such as a new sports team or at the start of the school year, can help build confidence in their ability to respond to common questions and lower their anxiety. So in summary, there are a wide range of risks and outcomes for our patients with cleft and craniofacial conditions. And though many of our kids are absolutely resilient, they do experience unique challenges related to social and emotional functioning as they navigate years of medical and surgical interventions. When we're aware of the challenges that our children and their families face and can have a sense of their unique risk and protective factors, we can work as a care team to provide targeted supports to address their needs and build their resilience. By helping our families overcome challenges, we can help them see their own resilience and empower them to engage in comprehensive cleft and craniofacial care to help their children. Thank you very much, and I welcome questions by email if there's anything that anybody wants to follow up on. Thank you.